Hi guys, if I'm audible and visible, please send your thumbs up in the chat box. Okay guys, so we are going to discuss today the bleeding disorders of stomach. These are very important topics asked frequently in exam. So let's start guys. First of all, can you tell me what is the most common cause of upper GI bleeding? The most common cause of upper GI bleeding, all of you know, that is peptic ulcer. So what is the most common cause? The most common cause of upper GI bleeding, that is peptic ulcer. Any patient who is having upper GI bleeding, can you tell me what is the first investigation done? So the first investigation done, that is endoscopy. So first investigation done in upper GI bleeding, that is endoscopy, right? Whenever we are performing endoscopy, on the basis of endoscopic findings, we have to assess that what are the risk of rebleeding. So how to assess the risk of rebleeding? There is a classification system, and this classification system is very important. What's the name? Name of this classification, this is Forest classification. So name of this classification, Forest classification, and you know it is based on endoscopy to predict the risk of rebleeding. Suppose you perform endoscopy and you can see this kind of bleeding. What is this kind of bleeding? This is active pulsatile bleeding. So obviously in cases of active pulsatile bleeding, there is high risk of rebleeding. If there is oozing, there is 1B. So what is 1A? Active pulsatile bleeding. 1B, that is oozing. What is 2A? In 2A, we are going to see a non-bleeding visible vessel. There is a vessel which is visible, but there is no bleeding. 2B means adherent clot. Adherent clot means there is evidence of bleeding, only clot is there, fresh bleeding is not there. 2C, at the site of bleeding there is black dot, and 3, clean base. It means there is no evidence of bleeding. So can you tell me in which cases there is high risk of rebleeding? In 1A, 1B, 2A. In 1A, 1B, 2A, these patients are having high risk of rebleeding. There is high risk of rebleeding. Clear? So there is high risk of rebleeding. Clear? Hello Mantasha Khan. Hello Tausif. So there is high risk of rebleeding. If it is 2B, that is adherent clot, can you tell me? Shinan, adherent clot here, can you tell me? There is intermediate risk. So in type 2B, there is intermediate risk, and whenever it is 2C and 3, here there is low risk. Nabi Raham, Indrani, hello Indrani, how are you? Okay, so guys tell me, for 2C and 3, you know there is low risk. Arvind, welcome Arvind. So it is Forest classification, it is based on endoscopy to predict risk of rebleeding. So what kind of questions we are expecting related to this classification? Examiners are giving the various categories, they ask the description, or they give the description, they ask the category, or they ask that in which of the following there is high risk, there is intermediate risk or low risk. So welcome Megha, welcome. So this is Forest classification, right? We discussed that most common cause of upper GI bleeding, that is peptic ulcer. Guys, this is easy question for all of you. Can you tell me what is the most common site of peptic ulcer? Easy question. Pratyosh, welcome with Pratyosh. What is the most common site of peptic ulcer? So guys, you know the most common, crazy doctor, welcome. So most common site of peptic ulcer, it is duodenum. Obviously first part of duodenum. So it is duodenum followed by stomach. So it is duodenum followed by stomach. Clear? So it is duodenum followed by stomach. Yes, Tausif, you are correct. And you know that in duodenum, what is the most common site? It is D1. That is first part of duodenum. First part of duodenum. Shefali, Tetusha, very good. Tesuya, Mantasha Khan, all of you are correct guys. Now easy question. You know that the location is fixed in duodenum. Usually it is first part of duodenum. So treatment of duodenal ulcer, it depends on location. Treatment of duodenal ulcer, it depends on location. And in gastric ulcer, the location, just a moment. So in duodenal ulcer, since the location is fixed, the treatment depends on complications. It depends on the complications, right? In gastric ulcer, the location is variable, and that's why the treatment of gastric ulcer, this is dependent on location. So treatment of gastric ulcer, it depends on location. Clear? So for that you should know, what? For that you should know the location of gastric ulcer. So there is a classification system. Thank you Bulbul Cute. So thank you. So there is a classification system for gastric ulcer. Guys, can you tell me the name? What is the name of that classification system for gastric ulcer? Easy question. Yes, what is the classification system? Guys, I am waiting for your reply. What is the classification system for gastric ulcer? Classification system. So, you know the name of classification system, this is modified Johnson's classification. So, you can see here guys, this is modified Johnson's classification. So, this is modified Johnson's classification, clear? So, this is modified Johnson's classification, modified Johnson's classification, clear? So, this is modified Johnson's classification. In that case, here you can notice that what is the location of ulcer? If the ulcer is located where? At incisura angularis, it is type 1. In type 2, there are two ulcers, one in the body and one in first part of duodenum. Type 3 you can see here, it is pre-pyloric. Type 4, high on lesser curvature, and type 5 you can see anywhere in the stomach. So, guys, you can see here type 1 ulcer located at incisura angularis, ulcer located at incisura angularis, clear? So, it is located at incisura angularis, incisura angularis. Can you tell me type 2? So, you can see that type 2 two ulcers are there, one in first part of duodenum and one in body. So, one in body of stomach, one in first part of duodenum. Type 3, you know that's pre-pyloric. Type 4, ulcer located high on lesser curvature. Where exactly? It's high on lesser curvature. So, ulcer located high on lesser curvature, and guys, you tell me what is type 5? What is type 5? Type 5 anywhere which is NSAIDs induced. So, ulcer which is NSAIDs induced, anywhere which is NSAIDs induced. So, ulcer anywhere which is NSAIDs induced. These are the 5 types. One easy question for all of you. Can you tell me what is the most common type? The classification system starts from 1, 2, 3, 4, 5. Tell me the most common type. Guys, 1, 2, 3, 4, 5. Tell me the most common type. Obviously, so you know that if a classification starts from 1, 2, 3, 4, 5, it is type 1. If classification starts from A, B, C, D, E, it is type A. So, in this case, all of you know that the most common type, it is type 1. So, the most common type, type 1. So, first question, type 1 is most common. Second, you know that rest all types are associated with blood group O, but type 1, it is associated with blood group A. Rest all associated with blood group O, but this one is associated with blood group A. Clear? So, this is the relation of blood group. Clear? Second question you can see, tell me about the acid secretion. Which type is having high acid secretion? Out of these, which one is having higher acid secretion? So, if you see type 2 and type 3, in type 2 and type 3, there is increased acid secretion. So, in type 2 and type 3, there is increased acid secretion, in type 2 and type 3, right? If there is increased acid secretion in type 2 and type 3, all of you know that for increased acid secretion we perform one surgery. Can you tell me the name? Which surgery is performed to decrease the acid secretion? Guys, tell me, what is the name of surgery performed to decrease the acid secretion? Yes, you know the name, it is truncal vagotomy. So, truncal vagotomy is routinely done in type 2 and type 3, but guys, for type 1, for type 4 and for type 5, in all these types what happens? There is normal or decreased acid secretion. So, normal or decreased acid secretion. If there is normal or decreased acid secretion, that is why for type 1, for type 4 and for type 5, we are not going for any kind of vagotomy. So, we are not going for any vagotomy. Nawazis Siddiqui, Pratyush, Mansi Wadi, all of you are correct, guys. So, we are not going to perform any kind of vagotomy. So, you can see here what is the treatment. So, you can see the treatment. Treatment of gastric ulcer for type 1, we are going for type 1. What is the treatment? For type 1, we are going for distal gastrectomy. Type 1, we are going for distal gastrectomy. Is the distal gastrectomy. What is the treatment for type 2 and type 3, guys? We discussed that for type 2 and type 3, we are going for truncal vagotomy plus entrectomy. Clear? So, this is truncal vagotomy plus entrectomy. And type 4, that is high on lesser curvature. So, special surgeries are done for type 4 since it is located high on lesser curvature. So, special surgeries are done, and what are those special surgery? You can see Sendis, Pouchet, Kelling-Madlener, Shoemaker. So, for type 4, these special surgeries are done. Type 4. And what is type 5? All of you know type 5 is NSAIDs induced ulcer. So if it is NSAIDs induced ulcer, we have to go for what? Stop NSAIDs. So stop NSAIDs since it is NSAIDs induced ulcer. So stop NSAIDs. Clear? So stop NSAIDs. Easy. So this is an easy question. So what did you see here? Since in the stomach location of ulcer is variable, location is not fixed. So what did you see here? The treatment depends on the location. But what about duodenal ulcer? The location is fixed, it is in the first part of duodenum. That's why the treatment of duodenal ulcer, that is dependent on complication. So guys, can you tell me what are the complications of peptic ulcer? Intractability, bleeding, perforation, gastric outlet obstruction. One question for all of you. Suppose a patient is having duodenal ulcer which is intractable, which type of surgery should be done? Guys, tell me. Which vagotomy should be done? Highly selective, selective or truncal vagotomy for intractable duodenal ulcer? Okay. Bulbul cute, Nabi Rahim, Tausif, factor 5 lead-in, Nabi, Rajgupta, Mantasha, tell me. Okay. Clear? So if intractable duodenal ulcer is there, it is not healing after medical management. In that case, we just go for highly selective vagotomy. But whenever there is recurrent duodenal ulcer, in that case, we go for truncal vagotomy. So here you can see if the patient is having intractable duodenal ulcer, the patients who are having intractable, so intractable duodenal ulcer, in these patients we are going for highly selective vagotomy. And if patient is having recurrent duodenal ulcer, in that case we go for truncal vagotomy. Now can you tell me, out of bleeding and perforation, which one is most common complication of peptic ulcer? Guys, tell me. Bleeding and perforation, which one is the most common complication of peptic ulcer? So bleeding, this is the most common complication of peptic ulcer. This is the most common complication. So this is the most common complication of peptic ulcer. That's bleeding. This is bleeding. And perforation, this is the most common complication of gastric ulcer. So this is most common complication of gastric ulcer. Most common complication of gastric ulcer, right? Which complication is rare nowadays? It's gastric outlet obstruction, which is rare. It's rare. So guys, how to remember? It's very, very easy. Can you see here? Bleeding is the most common complication of peptic ulcer. Perforation, it is most common complication of gastric ulcer. How to remember? BP, and usually BP is taken by intern, but sometimes PG. So it is BP taken by PG. How to remember? BP taken by PG. So bleeding, most common complication of peptic ulcer. Perforation, most common complication of gastric ulcer. Clear? Okay. Okay, right. So BP taken by PG, right. So these are the complications. So one by one we are going to discuss the management. We discussed that for intractable duodenal ulcer we are going for highly selective vagotomy. Now see, if patient is having ulcer, and where is the ulcer? You can see guys, ulcer is located on anterior wall or ulcer is located on posterior wall. Can you tell me what is the name of this artery? There is one artery here in relation to first part of duodenum, and posteriorly located ulcers are going to invade that artery. Guys, can you tell me the name? What is most commonly involved artery? Yes, responsible for bleeding in bleeding duodenal ulcer. No, Bulbul, Raghav, tell me. Artery responsible for bleeding, gastroduodenal artery. Crazy Dr. Mansi Wadi, very good. This is gastroduodenal artery. Very good guys. Gastroduodenal artery. So you know that this anteriorly located ulcers perforate and posteriorly located ulcers bleed. So if it is in the first part of duodenum, you know, anteriorly located ulcers, these are going to perforate. These are going to perforate. Posteriorly located ulcers bleed, and this is the famous question which was asked many times. Most commonly involved artery in bleeding duodenal ulcer, that is gastroduodenal artery. This is the gastroduodenal artery. So guys, how we are going to manage the perforation of first part of duodenum, how we are going to manage the bleeding duodenal ulcer? Okay, bleeding duodenal ulcer is very, very easy. You can see here. If there is bleeding duodenal ulcer, you can see this is the gastroduodenal artery which is responsible. So what you have to do, you just go inside the duodenum, duodenotomy. After that, you ligate the bleeding vessel After that, you perform the pyloroplasty. So, in cases of bleeding duodenal ulcer, first open the duodenum. We perform duodenotomy. Very good. Mantasha Khan, Raghav Sharma. Duodenotomy. After that, go inside and perform the ligation of bleeding vessel. So, we do the ligation of bleeding vessel. Ligation of bleeding vessel. Ligation of bleeding vessel. Plus, we perform pyloroplasty so that there is no stenosis. So, we perform pyloroplasty. Pyloroplasty. So, that is the treatment of bleeding duodenal ulcer, right? Next question was asked in FMG, in the last FMG this question was asked, there was image based question, and guys, there was one perforation in the first part of duodenum. They asked how to repair this perforation, right? It is very easy. What you do, you take a patch of omentum and put it here, and after that take 3 sutures and perform omental patch repair. So, for duodenal ulcer perforation, we perform, you can see here, this is omental patch repair. So, what is the name? We perform omental patch repair. So, that is omental patch repair. Clear, guys? So, this is omental patch repair. Can you tell me what is the name of this repair? Dr. Faizan, Factor 5 leading, Nawazish Siddiqui, Mansir, Crazy. Can you tell me what is the name of this repair? Easy question. What is the name of this repair, guys? Name. Preetham Patil, very good. Preetham, Factor 5 leading, both of you are correct. It is modified Graham's repair. So, guys, what's the name? This is modified Graham's repair. What's the name? This is known as modified Graham's repair. So, this is modified Graham's repair. We are going for modified Graham's repair. That is the treatment of duodenal ulcer perforation. Okay. Raghav Sharma, it is modified Graham's repair, right. Next, gastric outlet obstruction. One question for all of you. Can you tell me what is the most common cause of gastric outlet obstruction worldwide? This is a question for all of you. Guys, tell me. Most common cause of gastric outlet obstruction worldwide. Guys, tell me. Most common cause of gastric outlet obstruction. First, it is replied by Crazy Doctor, and he is absolutely correct. Yes, Nabi, Rahim, Mansawadi, all of you are correct, guys. Most common cause, it is carcinoma stomach. Carcinoma stomach. Okay. Next question, what is the most common site of gastric outlet obstruction in peptic ulcer? In peptic ulcer, what is the most common site? Raghav, Kumar, Mansi, Nabi Karim, Tausif, all of you are correct, guys. Now, can you tell me what is the most common site of gastric outlet obstruction in peptic ulcer? Yes, first part of duodenum, because first part of duodenum is the most common site of peptic ulcer. There is stricture formation, sometimes there is inflammatory edema. So, it is D1, that is the first part of duodenum. Guys, it is first part of duodenum. Clear? How to make the diagnosis, can you tell me? Gastric outlet obstruction, it is diagnosed by, what's the name of investigation? Atur Rahman Fakir, very good. How to make the diagnosis of gastric outlet obstruction? Let me see who is the genius over here. Tell me the name of the test. Crazy Doctor, it is saline load test. So, what's the name? This is saline. So, this is saline load test. It is saline load test. Clear? Saline load test. Okay. Gastric outlet obstruction. Diagnosis is done. What's the management? Let me tell you here. In majority of patients, there is ulcer, and because of this ulcer, this patient is having edema. So, ulcer is there. Because of the ulcer, there is edema. When edema is there, what we do? Nothing. When patient comes, we stop giving anything orally. So, NPO, that is nil per oral. For 48 hours, don't give anything orally. So, patient should be NPO for 48 hours. We give IV fluids. One question is for all of you. Can you tell me what is the fluid of choice? Faizan, Nabi Rahim, Chetana Vishwas. Guys, tell me, what is the fluid of choice in patients who are having gastric outlet obstruction? Let me see. Crazy Doctor, Bulbul Cute, Shefali Jamini, Nabi Rahim, Nawajesh, Ataur Rahman. Yes, majority of you are correct, guys, but some of you marked ringer lactate. That's wrong. It's not the ringer lactate, it is normal saline. Let me tell you. Gastric outlet obstruction, either because of anything, if it's because of peptic ulcer or if it's because of hypertrophic pyloric stenosis, you know, in both of these cases, it is because of, in both of these cases, we give what? Normal saline. So, fluid of choice is normal saline. This you have to remember. It is normal saline. So, patient should be NPO, we have to give the fluid, normal saline, we have to perform the gastric lavage so that whatever the food stuff is there in the stomach, you take it out, and after that whatever the inflammatory edema is there, it is going to settle and majority of patients are going to improve. Imagine if the patient is not improving, what is the problem? In such patients there is stricture. In such patient there is stricture, and in this case what's the treatment? Treatment of choice is the truncal vagotomy plus enterectomy. The treatment of choice is the truncal vagotomy plus enterectomy, and in some cases this enterectomy is not possible, guys. Why? Because of extensive fibrosis. So if it's not possible, can you see what we are doing? We are performing the gastrojejunostomy. So if it's not possible, in that case we perform gastrojejunostomy. So what is the alternative treatment here? You can see is the truncal vagotomy plus gastrojejunostomy. So both of these are questions which are asked frequently. Treatment of choice, truncal vagotomy plus enterectomy, and what is the alternative treatment? That is truncal vagotomy plus gastrojejunostomy. So Tausif, Elite Club, Raj Gupta, Kalpesh Patel, Raghav Sharma, all of you are correct, guys. It is TVGJ. So read the question carefully. Truncal vagotomy plus enterectomy, alternative treatment TVGJ. Clear? So this is the treatment of gastric outlet obstruction. Next question. We are going to discuss the bleeding disorders. Most important is Mallory-Weiss syndrome. Let me tell you guys, you will be having this kind of history. See the history. Office going male, attended office party. There is history of binge drinking. I am repeating. Office going male, attended office party, there is history of binge drinking, and after binge drinking patient is having thoracic pain, there is vomiting, there is cervical subcutaneous emphysema. Can you tell me the diagnosis? Vomiting, thoracic pain, cervical subcutaneous emphysema, tell me the diagnosis. Guys, tell me. Yes? No. Let me see. Who is going to reply? Yes, Dr. Faizan Ansari, Dr. Mansi, yes, Moinur Rahman, very good. Everybody is correct, guys. It's Borhav syndrome. Now see the second history. Office going male, his history of binge drinking in office party. Now this is painless condition, but patient started having hematemesis. Now tell me what's the cause. If patient is having hematemesis and it's painless, binge drinking history is there. Now what is the cause? Raj Gupta, Raghav Sharma, tell me. Now it's Mallory-Weiss syndrome, guys, you got it? So see, in both, what is the common thing? There is multiple vomiting, forceful vomiting, history of binge drinking. Both Mallory-Weiss syndrome as well as Borhav syndrome, these are seen in alcoholic males. So you can notice here in this image. In this image, you can notice that there is partial tear, and this partial tear, it's involving only mucosa and submucosa. Partial tear involving only mucosa and submucosa. Most common site, it's cardia. You can notice in this image, it is cardia, and what is the exact location? Just below GE junction, it is cardia. This you have to remember, it is not at, it is just below. So this is just below GE junction. This you have to remember, guys. Let me tell you, in examiner gives you above G junction, at G junction, just below G junction, anywhere about G junction, just below G junction, and we discussed it is more common in males. What kind of males? Alcoholic, and usually these males are having multiple vomiting, forceful vomiting, history of binge drinking. In these males, you are going to find history of binge drinking. That is Mallory-Weiss tear. Now one question for all of you, can you tell me what is the artery responsible for bleeding? This question was asked in AIMS. Let me see who is going to reply correctly. What is the artery responsible for bleeding? CB Medical, Mehan, Yasmin, Mantasha, Mansi, tell me. Moinur Rahman, first person to reply Moinur, followed by Mansi. Very good, Moinur Rahman. It is left gastric artery. Crazy doctor, Tausif, Karthik, Parik, Yamin, Polami Chatterjee, Kumar, all of you are correct, guys. It's left gastric artery. So this is the largest vessel supplying the stomach, left gastric artery, right? Whenever bleeding is there, let me tell you, in majority of cases there is minor bleeding, and if minor bleeding is there, in majority of patients there is no symptom. Second, this condition is painless. Can you tell me in what percentage there is massive bleeding? Massive bleeding is only seen in 20% cases, and if there is massive bleeding, obviously these patients are having hematemesis. So if there is massive bleeding, these patients are having hematemesis. These patients are brought to you in emergency. And you told me most common artery responsible, that is left gastric artery. Clear? So one question for all of you, for any bleeding disorder of stomach, can you tell me what is the investigation of choice for diagnosis? Guys, Chandra Prakash, Sonwani, tell me, what is the investigation of choice for diagnosis? Guys, tell me. For any kind of bleeding disorder, what is the investigation of choice for diagnosis? Nabi, Mantasha, Tausif, Karthik, Parik, guys, almost everybody is correct. We have to go for endoscopy. So we go for upper GI endoscopy. Endoscopy. Next, we discuss that in Mallory-Weiss syndrome, in majority of cases, bleeding is minor. It is painless. Nothing is done, only conservative management. But imagine, even after conservative management, there is no improvement. You tell me what should be the next best step. Paulami Chatterjee, very good. CB Medical, Raj Gupta. Suppose conservative management, yes, is there, but still patient is bleeding. There is no improvement after conservative management. What should be done next? Very good. So after that, we go for endoscopy. We go for endoscopy plus electrocoagulation. Endoscopy plus electrocoagulation of bleeding vessel. Electrocoagulation. Suppose it is not available or failed. If it is not available or failed, the next step is angioembolization. So if it's not available or failed, the next step, that is angioembolization. This is angioembolization. Angioembolization. Suppose this one is also not available or failed. In that case, we go for what? Open surgical ligation. So in this case, we go for open surgical ligation, right? So this is the common step in upper GI bleeding. Initially, you try to control the bleeding with the help of endoscopy. If you are not able to control, go for endoscopy with electrocoagulation. Not able to control, go for angiography with embolization. Still, it's not available or failed. In last, we are going for open surgical ligation. Clear, guys? So this is how we manage. Okay. Next, you can see very important topic, Dialfoy's lesion. Can you see here what's the problem? In this image, you can notice that this patient is having large arteriole. Can you tell me the diameter? Anybody tell me diameter? Large arteriole, how much is the diameter? Yes, diameter, it is 1 to 3 mm. Guys, it is 1 to 3 millimeter. Diameter 1 to 3 millimeter. Faizan, very good. Nabi Rahim, very good. Located within 6 to 10 centimeter of G junction. 6 to 10 centimeter of G junction. Clear? Placed just below mucosa. So this is placed just below mucosa. It is placed just below mucosa. Guys, this is large arteriole. It is arteriole. It's not the artery. If it is arteriole, acid is going to work on the wall of arteriole. The wall is injured and this kind of bleeding is there. Can you tell me, according to Forest classification, what is this type? Tell me, guys. What is this type according to Forest classification? Faizan, tell me. Yes, you are correct, pulsatile bleeding. What is this type according to Forest classification? So according to Forest classification, what is this type? Yes, type 1. Very good, Arvind. It is type 1. It means there is high risk of rebleeding. So you can see here, guys, there is active pulsatile bleeding. So these patients are having massive bleeding. There is rebleeding. Because of that, there is recurrence. So patient is having hypotension. So if you see the clinical features, in these patients, there is massive bleeding. These patients are having massive bleeding, and because of rebleeding, what happens? There is hypotension with recurrent hypotension. Massive bleeding with recurrent hypotension. So it's recurrent hypotension. Now, one question for all of you, tell me again, what is the investigation of choice? Supwarna Jindal, Moinur Rahman, tell me, what is the investigation of choice for diagnosis? All of you know the correct answer. It is endoscopy, obviously. So we go for endoscopy. So what we go for? We go for endoscopy. Endoscopy, clear? Now how to control? See, here massive bleeding is going to occur. So there is no role of conservative management. We have to go for endoscopy. If not able to control the bleeding, we have to go for angioembolization. So management, you can see, guys, management. First, endoscopy. So we go for endoscopy plus electrocoagulation. So it is endoscopy plus electrocoagulation of bleeding vessel, right? Suppose it is not available or failed. In that case, we go for angiography, angiography plus embolization. angiography plus embolization, still it's not available or failed, in that case we go for open surgical ligation. We go for open surgical ligation, clear? So, this is how we manage Diel-Foy's lesion, Diel-Foy's lesion, clear? So, this is how we manage Diel-Foy's lesion, clear? Mantasha, Karthik, Mansi, Chetna, very good. Next, this is watermelon stomach. Guys, can you tell me what is the full form of GAVE? This is watermelon stomach. What is the name? GAVE. What is the full form? It's written gastric antral vascular ectasia. So, first question you can see here, it is looking like watermelon. There are dilated vessels at the antrum. Can you see? Parallel stripes of dilated vessels. Can you see here? These are parallel stripes of dilated vessels located at antrum. Clear? It is looking like rind or covering of watermelon. So, this is watermelon stomach. Can you tell me what is the most common site? It's given here. It's already written. Antrum, antral. So, antrum. Next question for all of you. Can you tell me the pathology? Mansi, Mantasha, Chetna. Tell me what is the pathology here? Pathology. Patients are having vascular ectasia. So, pathology. The patients are having vascular ectasia. These patients are having vascular ectasia. So, in watermelon stomach there is vascular ectasia. Clear? Patients are having vascular ectasia. What is the problem? There is vascular ectasia. So, this vascular ectasia leads to occult bleeding, and if there is occult bleeding, it is more common in females. Can anybody tell me, because of occult bleeding, what is the manifestation? Raghav, tell me what is the manifestation if there is occult bleeding in watermelon stomach? Easiest question. There is occult bleeding, so what is the manifestation? Anemia, very good. And can you tell me what is the symptom of anemia? Patient is having fatigue. So, see the clinical features, guys. These patients are having occult bleeding. Because of occult bleeding, the patients are having what? Patients are having anemia. The patients are having anemia, and because of anemia, the patient is having fatigue. The symptom is fatigue. Clear? There is chronic liver disease in approximately 25% patients. So, 25% patients have chronic liver disease. Again, one question for all of you. Again, one question. One question for all of you. What is the investigation of choice for diagnosis, guys? It's easy. What? Endoscopy? It's endoscopy plus biopsy. Can anybody tell me why I go for biopsy? Why I am going for biopsy in this patient? Crazy doctor, it is endoscopy plus biopsy. Dr. Juice, can you tell me why we go for biopsy? On endoscopy, you are going to see there are parallel stripes of vessels which looks like rind or covering of watermelon. Yes, Chetna, you are correct. Only Chetna, one person is correct. Chetna. No, it's not for ruling out malignancy, guys. You have to confirm whether patient is having vascular ectasia or not. So, endoscopy, here parallel stripes of vessels which look like rind or covering of watermelon, and biopsy, why? To confirm the vascular ectasia. So, biopsy, why? Patient is having vascular ectasia. Clear? So, diagnosis is done. Can anybody tell me the treatment? Let me see who is the genius over here. The treatment is totally different. Can anybody tell me? Suvarna Jindal, tell me the treatment. The treatment is totally different. Very good. Very good. Moinur Rahman, first person to reply correctly. Kritarth Parikh, second person. Mansi Wadi, third. Crazy doctor, fourth. It is APC, guys, argan plasma coagulation. So, what we go for? We go for argan plasma coagulation. So, we go for argan plasma coagulation. Argan plasma coagulation. So, we go for argan plasma coagulation. The second option, we can go for endoscopy plus electrocoagulation. So, we go for endoscopy plus electrocoagulation. Electrocoagulation. Clear? So, guys, bleeding disorders of stomach is very important. Mostly they are asking Forest classification. So, Forest classification, it is based on endoscopy to predict the risk of rebleeding. Can you tell me, this is the rapid fire round for all of you guys, 2-3 basic questions which are asked frequently. Tell me, what is the most common site of peptic ulcer? Easiest question. Yes, this is rapid fire. Rapid fire. Clear? Most common site of peptic ulcer? Yes, all of you know it is first part of duodenum, right? We discussed that there is a classification system for gastric ulcer. What's the name of the classification system? Classification system for gastric ulcer, what's the name? Yes, it is modified Johnson's classification, right? What was the treatment of choice for Duodenal ulcer perforation. Duodenal ulcer perforation. Perforation is located at the first part of duodenum. What is the name of surgery? Name of surgery. Perforation is first part of duodenum. What is the name of this surgery? Yes, modified Graham's repair, that is also known as omental patch repair. Next question. Two questions I am asking. Let me see who is the genius. Most common artery responsible for, see the question correctly, read it, okay. Most common artery responsible for duodenal ulcer bleeding and most common artery responsible for gastric ulcer bleeding. First, most common artery responsible for duodenal ulcer bleeding. Duodenal ulcer bleeding, most common artery responsible for duodenal ulcer bleeding. Gastroduodenal, very good. And most common artery responsible for gastric ulcer bleeding, very good. Shefali Gemini, very good. All of you are correct, guys. All of you are correct. Next, what is the most common site of Mallory V steer? Most common site of Mallory V steer. Mantasha, very good. Mallory V steer, most common site. It is at GE junction, above GE junction, just below GE junction. At GE junction, above GE junction, below GE junction. Yes, Shefali, very good Shefali, very good Mansi, very good. So, it is just below, guys. I am telling you, we discussed, it is just below, it is not at or above, it is just below GE junction, that is cardia. Next question, what is the artery responsible for Mallory V steer? Artery responsible for bleeding in Mallory V steer. Artery responsible for bleeding in Mallory V steer, that is left gastric artery. Next, what is the investigation of choice for diagnosis of watermelon stomach? Investigation of choice for diagnosis of watermelon stomach. Watermelon stomach. Very good. Endoscopy plus biopsy. It is endoscopy plus biopsy, and we discussed what is the treatment of choice for watermelon stomach. It is argon plasma coagulation. Somebody was asking that, sir, what is the difference between herniatomy, herniorrhaphy, hernioplasty? Herniatomy, you know, guys, what is herniatomy? Suppose this is the hernia sac. This is the hernia sac. This is the bowel. So, what we do? Yes, herniatomy. We reduce the bowel, we reduce it. After reducing it, what we do? We excise the sac and we close the defect. This is herniatomy. Whenever after herniatomy, you repair it with sutures, that is known as herniorrhaphy. And if you are going to repair it with mesh, that is hernioplasty. So, only hernia surgery in which we excise the sac, reduce the content and close the defect, herniatomy. If you repair the defect with sutures, that is herniorrhaphy, and if you are going to repair it with the mesh, that is known as hernioplasty. Clear, guys? So, this was the topic of today, bleeding disorders. This is very, very important. Sometimes we are expecting a question in medicine, surgery, sometimes in pathology, and in one particular exam, all three were asked. What were the three questions? Mallory V steer, there was watermelon stomach, and Diel-Furst lesion. So, guys, this was all about today's session. Thank you very much, and all the best for upcoming exam. Keep studying. Keep studying. You are going to crack the exam with flying colors. All the best, guys. All the best, and thanks for joining.
This has